Hello NCLEX Crusaders, how are you? Let me know if you can see my presentation, if you can see me, and if you can hear me, so we can begin today's training. Welcome everyone. It's very good to see you here. Just confirm for me when you can, if you can see the presentation, and if you can hear me, so I can begin. All right, perfect. It looks like you're able to hear me perfectly fine. All right. Hello, let's begin. Welcome everyone to NCLEX Crusade International YouTube channel. Today we are on day number 12 of our NCLEX journey, how to pass the NCLEX step by step. So if you are a nursing student, you are in nursing school right now, or you're done with nursing school and you're preparing for the NCLEX, this channel can help you prepare successfully. And today we're gonna be talking about a very nice NCLEX topic on the different types of shock. As you know, everything that relates to airway, breathing, circulation, well, it's extremely important for the NCLEX. And of course, shock is among those topics that appear on the NCLEX very frequently. You can see questions select that apply. You can see prioritization questions on the different types of shock. And you can even see a full onboard case study. So I think today's training is going to be extremely beneficial and important for your NCLEX success. If you're new to our YouTube channel, to our Facebook page, just comment in the comment section that you're new. Let me know where you are joining from. And of course, if you're not subscribed to our YouTube channel, go ahead and do it so you don't miss any of our information. And of course, like today's live if you think is beneficial to you. So let's begin. Let's begin the training. All right, so first, let me share with you the question we're going to be discussing today. If you know the routine, you've seen the previous videos, video 1 to 11. Basically, I always discuss an NCLEX style question, but prior to giving you the answer of that specific NCLEX question, I like to discuss some nursing content, some critical thinking, so that you can develop that nursing knowledge and develop the ability to apply nursing content. So today's topic, I'm sorry, I've had this respiratory process for a while, so excuse me. So we're going to be talking about shock today. As you can see in this question, we're dealing with a patient in ICU. The nurse is providing care to the patient in ICU. The patient is hypotensive and is receiving continuous infusion of dopamine. Basically, you want to think now, what drug category is this medication? Dopamine, what is its effect? How can it help the patient with hypotension? And then it says, which assessment finding indicates that the infusion rate may need to be adjusted. What does that indicate? Are we talking about the intended effect of a medication, or are we talking about a side effect or adverse effect of a medication? Because if the question says which finding indicates that the medication need to be adjusted, usually we're dealing either that the medication is being subtherapeutic and we have to increase the rate, or the medication is being toxic to the patient and we're seeing adverse effects. So that is usually how these questions are presented, and I will give you the answer to this question at the end of today's training. But before, I want to start with the definition of shock, because this question deals with a patient in shock. So what is a shock? What are the different types of shock? So as you know, the definition of shock is a life-threatening physiologic condition in which there is inadequate blood flow to tissues and cells of the body. Pay attention to the definition. It doesn't say there is an insufficient amount of blood. It talks about blood flow to the tissues, because as you will start learning today, depending on the type of shock, the different clinical manifestations that your patient is going to experience. But it doesn't matter which type of shock we're dealing with, we are dealing with a life-threatening condition. Now, there are 3 stages of shock. If you know what these stages are, comment in the comment section. What do you recognize as the 3 stages of shock? I hope that you remember this, because this is important in understanding the clinical symptoms your patient is going to experience, because depending on which stage of shock your patient is, you're going to see different clinical manifestations, and also it's going to be different the way we treat the patient. Stage number 1, compensatory stage. Stage number 2, progressive or maintenance stage. And stage number 3, irreversible or refractory stage. What I want to do, I want to go stage by stage and explain to you what is going on these 3 stages of shock. As stage 1 states, stage 1 is compensatory stage. What does that mean, Professor? Basically, there are going to be different compensatory mechanisms trying to balance the patient condition, trying to bring the patient back to homeostasis, right? We're trying to equilibrate the patient's condition. So the patient could be in shock, and then, thanks to the compensatory mechanisms, a patient in shock, we can even see a normal limit blood pressure. So we might not even see severe hypotension at this first stage of shock. Why? Because the compensatory mechanisms are sufficient at first to maintain an adequate blood pressure. So let me explain to you this graph, this photo, so you understand the compensatory mechanisms. Let's say that something happened and the patient developed a shock state. What's going to happen? This shock is going to decrease the tissue perfusion, and is going to decrease oxygenation to these tissues. So far, we know that a shock occurred for the different causes that we're going to talk later, and then the perfusion to the tissues is decreased, and the oxygenation to the tissues is decreased as well. Now, as a compensatory mechanism, there's going to be what is known as activation of the homeostatic response. Another fancy word for compensatory mechanisms. What are these compensatory mechanisms? What are they? Well, let's look at the cardiovascular response. There's going to be an increase in the sympathetic response. What does that mean? increase heart rate, increase blood pressure, and increase cardiac contractility. What's going to be the end result? Increase cardiac output. So the body is trying to compensate by increasing the cardiac contractility and providing more oxygenated blood to the tissues that we already mentioned that is suffering a tissue perfusion decrease and decreased oxygenation. So that is what the heart is doing. On the other hand, the lungs and the respiratory compensation is as follows. There's going to be an increased respiratory rate. Why? Remember, there is decreased oxygenation to the tissue. So the body natural response is, if I increase the respiratory rate, I'm bringing more oxygen, expelling more CO2, so that oxygen is going to be able to go to the tissue and perfuse the tissue with oxygenated blood. That is what the body is trying to naturally accomplish. Another response, we see the involvement of the renin-angiotensin activation. And I'm not going to spend 20-30 minutes explaining the whole renin-angiotensin system, the cascade, because it's not the purpose of today's training. But you know that if the renin-angiotensin activation occurs, the end result is going to be an increase in the reabsorption of sodium and water. And why is that important? What happens when there is an increased reabsorption of sodium and water? Well, there's going to be more fluid available, which in turn is going to increase the preload of the heart to be able to circulate more fluid and oxygenated blood to the different parts of the body, and the kidneys kind of like shut down, decrease urinary output. Why? We want to save fluid. We want to save fluid for adequate circulation. And then, on the other hand, we also have an increase in the catecholamines and cortisol, basically to provide an increase in glucose for metabolism. Remember, glucose is the energy. We need that glucose for an adequate functioning. With this activation of the homeostatic responses, with the activation of the cardiovascular system, activation of the respiratory system, the kidneys involved in the reabsorption of sodium and water, increasing the preload of the heart, decreasing the urinary output, and then the effect of the catecholamines, increasing cortisol, increasing glucose, helping with metabolism, the end result is going to be a restoration of tissue perfusion and oxygenation. Now, is this going to be forever? No, because this compensatory mechanism has a threshold. There comes a time that the heart cannot do anymore, the lungs cannot do anymore, and the kidneys can no longer compensate. So we have to treat the problem. But this is what happens in stage 1 of shock. Compensatory mechanisms are involved to help compensate for the condition. Does that make sense? Do you now understand why a patient in the first stage of shock, we can see a normal blood pressure? Let's go to stage number 2, known as the progressive stage. So in the second stage of shock, the mechanisms that we just talked that regulate blood pressure can no longer compensate, and now we're going to see something decrease drastically, which is the mean arterial pressure. or MAP. Usually we're going to see a mean arterial pressure below 65. So now our patient is going to be significantly hypotensive. We're going to see a systolic BP of less than 100, a decrease in diastolic blood pressure. So decreasing systolic blood pressure and decreasing diastolic blood pressure from the baseline. And now, because of the decreased blood pressure, we're going to see alter mental status changes in the mental status. So this is important to know and understand. Stage number 2, we can treat the patient and continue the compensation process. Not only what the body is able to do by its own, but now with pharmacological intervention, we can also help the patient. Stage number 3. This is a bad stage. This is what is known as the irreversible stage. What is the irreversible stage? It represents the point within the shock crisis that organ damage is so severe that the patient no longer responds to treatment and cannot survive. So this is the point of no return. Only a miracle can bring the patient back. At stage 3, there is severe multi-organ damage. So it doesn't matter how much treatment you give, the blood pressure is going to maintain low. The patient is going to develop other conditions such as metabolic acidosis. And then, due to the anaerobic metabolism, the patient is going to develop worsening lactic acidosis. The multi-organ dysfunction continues to progress, respiratory system dysfunction, even with mechanical ventilation. The cardiovascular system is ineffective for an adequate tissue perfusion, and the patient dies. Irreversible damage. So now you know the different stages of shock. But let's go to the next important topic. What are the different types of shock? There are 4 main types of shock: hypovolemic, cardiogenic, vasogenic or distributive shock, and obstructive shock. So let's go in one by one so you understand the differences in between each one of these types of shock. Let's begin with the most common type of shock, which is the hypovolemic shock. It's defined as a shock caused by internal or external blood or fluid loss. So whether it is internal bleeding or a patient has a wound, a stab wound, gunshot wound, external bleeding, the mere fact is that the blood and fluid loss is massive. What needs to happen for a hypovolemic shock to occur? There needs to be at least 50% of circulating volume lost. So if it's only a little bit of blood loss, it would not take the patient into a hypovolemic shock. But if 50% or more, 15, not 50, 50 is dead, 15% of circulating fluid volume is lost, patient is going to go into hypovolemic shock. What are the different causes? Gunshot wound, stab wound, serious bleeding from a ruptured organ, a spleen rupture, vascular rupture, such as AAA and aortic abdominal aneurysm rupture. We talked about this in previous live trainings. extensive trauma, or severe dehydration. So hypovolemic shock deals with the loss of fluids, loss of blood. Cardiogenic shock is a different problem. Cardiogenic shock is caused by failure of the pump. We have failure of the heart. The heart cannot pump the blood. There is blood, but the heart is not able to pump it. So what's going to be the end result of a cardiogenic shock? Diminished cardiac output. So you now understand the difference between an hypovolemic shock and cardiogenic shock. One is fluid loss. This one is the heart not doing its job accordingly. What are the causes of cardiogenic shock? Myocardial infarction, myocarditis, endocarditis, drug overdose, poisoning. These are the different causes for cardiogenic shock. What is a third type of shock? Vasogenic or distributive shock. So notice this. In a vasogenic or distributive shock, there is sufficient blood volume, but there is an extreme vasodilation affecting organ perfusion. So within the vasogenic or distributive shock, there are different shocks, and you know them all. Septic shock, anaphylactic shock, neurogenic shock. So what is a septic shock? It's basically a generalized infection affecting the vascular system. So due to this generalized infection creating massive vasodilation, the patient goes into vasogenic shock. Septic shock. Anaphylactic shock, you know, a severe allergic reaction to a food, substance, medication. And lastly, neurogenic shock. Basically, there is loss of nervous system activity because of a spinal cord injury. Could be vehicle accident, sports injury, assault from a fall, etc. And lastly, we need to talk about the obstructive shock. So what can you learn about obstructive shock? Obstructive shock is a type of shock caused by a physical obstruction that reduces the filling or outflow of blood from the heart that results in a reduced cardiac output. What is an example of an obstructive shock? What are some causes of obstructive shock? Well, we have to talk about cardiac tamponade. And there was a live training on cardiac tamponade. Tension pneumothorax. Superior vena cava syndrome. We even talked about that in one of the live trainings. Abdominal compartment syndrome. Pulmonary embolism. And severe valvular stenosis, whether aortic or mitral. We talked about that. So I don't know if you're here with me, but if you're interested in passing the NCLEX and you're weak in content, you need to be looking at these live videos, because guess what? It's here on YouTube, it's free, and I'm going above and beyond in teaching you not only the critical thinking that you need, not only that, not only strategies, but even some content. So do not miss the opportunity to learn and it's here in our YouTube channel. So if you are enjoying this live training, if they're making a difference in your NCLEX preparation, share it with other nurses and like the video. Like this training right now. If you're here live, you're sitting live right now in front of me, like this video. It helps us out a lot. Like this live training right now. So, let's continue. You know now the different stages of shock. You know the different types of shock. But now let's go to the core of nursing. What are the assessment findings in a patient with shock? So there's going to be some parameters that you need to be monitoring closely in a patient in shock. So the video is blurred. I don't see anything. Should be fine. The camera gets kind of wild every once in a while, but you should be able to see me okay and see the presentation. Okay. So me blur is not too important. The presentation needs to be good, so you can read it, and most important too, you can you're able to hear me. Okay. So the clinical findings, the assessment that is important to monitor closely. We have to monitor cardiac output, mean arterial pressure, central venous pressure, cerebral perfusion pressure. So there are several contexts that you need to know. When we talk about the cardiac output, remember that the cardiac output reflects blood flow reaching the tissue. Normal cardiac output 4 to 6 liters per minute. The mean arterial pressure is the amount of pressure that blood is placing on the walls of the vessels as the blood leaves the heart. Normal mean arterial pressure is between 70 and 105. So, what is the goal in the treatment in a patient with shock is to maintain a mean arterial pressure above 65 at all means. When the mean arterial pressure is below 65, the organs are not well perfused. So we have to monitor this. Central venous pressure. It measures the pressure in terms of the right ventricular preload. So basically measures the pressure of blood returning from the body to the heart. What is normal? The normal central venous pressure is between 3 to 8. So what if we see an elevated central venous pressure? What does that indicate? An elevated central venous pressure indicates right ventricular failure and volume overload. What does a low venous pressure indicate? Central venous pressure. Then that indicates hypovolemia. Now, this next slide that I will be sharing with you is a gift for this presentation. With this next slide, it makes watching this live training a good purpose to be here, because this is something that nursing students and even doctors in medicine, in medical school, struggle to learn. The pathophysiological changes seen in the different types of shock. Not only that, not only understanding or knowing the changes, but understanding the why. So we're going to focus on CVP, central venous pressure, CO, which is cardiac output, and systemic vascular resistance. So how are these three parameters changed in the different types of shock and why? Do you want to learn that? Do you want to know that? Comment in the comment section that you really want to know this. So let's talk about hypovolemic shock. So remember, what is hypovolemia? There is no sufficient circulating volume. So there is not enough blood, not enough fluid. So because there is not enough blood for the heart to pump out, what's going to be the clinical findings? Decrease central venous pressure, decrease cardiac output, but increase systemic vascular resistance. Now you have to think, why? Why decrease central venous pressure and why decrease cardiac output? There's no blood. The volume is low. So it doesn't matter how hard the heart pumps, there's not enough blood to circulate. Now, what does the systemic vascular resistance do? Why is that increased? Because as a compensatory mechanism that you know already from the beginning of the presentation, there is peripheral vasoconstriction trying to compensate for the low volume. See how it makes sense now? See why it makes sense now that a patient in a hypovolemic shock, the CVP-CO is going to be decreased while the systemic vascular resistance is increased. Now, how about cardiogenic shock? How does it look in a cardiogenic shock? Well, what is a cardiogenic shock? Remember, now is failure of the cardiac pump, the heart, failure to pump. So the heart is not able to pump, is not able to manage the pressure, the same amount of blood that is usually dealing with. Now it's not able to manage that pressure. The central venous pressure increases, but because the heart is not able to pump the blood out, the cardiac output is decreased. And still, as a compensatory mechanism, there's still systemic vascular resistance increase. So the cardiac output is decreased, but there is activation of the autonomic nervous system producing vasoconstriction to compensate for the weak heart, but with negative results. So now you can see why in these two different shocks, the CVP is different and the cardiac output is the same and the systemic vascular resistance is the same. So in other words, the difference between a hypovolemic shock and cardiogenic shock in comparison to these clinical manifestations, the cardiac output and systemic vascular resistance is the same, but the central venous pressure is different. Why? In hypovolemic shock, it's low because there is not enough volume. In cardiogenic shock, it's high because although there is volume, the heart is not able to manage the pressure now with the same amount of volume that is used to dealing with. And then, in both conditions, since the cardiac output is decreased, the tissues, they're saying, hey, where's my oxygen? Decreased perfusion. And the autonomic nervous system compensates by increasing the vascular resistance, creating vasoconstriction to try to send more oxygenated blood to the different tissues. Lastly, vasogenic, septic, and neurogenic shock. So, when we talked about septic shock, we know that it is caused by a systemic infection. What is something that you need to remember in vasogenic or distributive shock? Remember, there is volume. There is sufficient volume circulating. But the problem is that there is severe vasodilation that is going to diminish the systemic vascular resistance. So one thing that you're going to see in vasogenic shock that we didn't see in hypovolemic and cardiogenic shock is that the systemic vascular resistance is decreased. So what is going to be my central venous pressure? The central venous pressure is going to be low in both septic and neurogenic shock, both pertaining to vasogenic shocks. So notice the central venous pressures are both low, but the cardiac output, one is high and one is low. Why? Why in septic shock the cardiac output is higher, but in neurogenic shock is lower? What is going on? What is the difference? Remember that in neurogenic shock, there is interruption of the sympathetic innervations to the peripheral vasculature. The heart is not going to be able to receive the signals to work harder, to improve cardiac contractility, that's going to help to improve cardiac output. The heart is not able to manage this because the nervous system response is blocked. So what's going to be the end result? There's going to be a deficit in the vasomotor tone. There's going to be decreased return of the blood to the heart, decreased cardiac contractility, and decreased cardiac output. So we're going to see both the CVP and the cardiac output decrease as well as systemic vascular resistance. So the vasogenic neurogenic shock is the one that everything is low. So you may say, well, what causes vasodilation in this vasogenic shock? Because in the other shocks, we're dealing with vasoconstriction. Why vasogenic shock, we're dealing with vasodilation? Because if it's a septic shock, different bacterial toxins causing sepsis creates systemic vasodilation. In the case of an allergic organic substance release or histamine, it's going to help with that. It's going to cause that vasodilation. And in the case of an injury, disruption of the autonomic nervous system in the neurogenic shock, that's going to cause severe vasodilation. So now you can see and understand the different clinical findings on the different types of shock. Kat, hi professor, just dropped to say hi. I passed my NCLEX last week. Your videos helped me a lot. It made me have the ability to answer the questions more easily. Thank you. Thank you, Kat. Congratulations. Thank you for coming back and giving us the good news. All right. Well, now you know the different types of shock, the different stages of shock. You know the nursing assessment, but what are the interventions? What are we going to do for this patient? What's going to be the treatment? Well, the treatment is going to depend on the cause of the shock, the type of shock. Although the clinical manifestations are pretty similar, as you could tell already from the presentation, there are differences in between shocks. But there are some interventions that are pretty standard. For example, clients in shock, we use a central venous and pulmonary artery catheters to monitor hemodynamic status. It's important to assess for central venous pressure, urinary output, heart rate, clinical manifestation, mental status, Q5, Q15 minutes. So usually between 5 to 15 minutes, we're assessing, or more often, we're assessing vital signs, blood pressure, central venous pressure, arterial pressures. Oxygen. Oxygen is administered to assist with tissue perfusion. In some of the shock, isotonic electrolyte intravenous solution, such as LR, normal saline, is used frequently. Rapid infusion of volume expanding fluid, including whole blood, plasma, plasma substitute, such as colloid fluids. Now, of course, if the problem is not volume, is the heart pump, then of course we're not going to be doing a rapid infusion of fluids, because we're going to put the patient in a worse condition. Whole blood is often used, is effective, but it is used with caution because of the risk of transfusion reaction. Cardiogenic medications such as digoxin, dopamine, which is one of the medications in the medication on the question that we're dealing today. Norepinephrine. These medications are used to improve perfusion in shock. They are administered intravenously via an infusion pump and often via a central line. NCLEX tip: for this medication, an infusion pump is required because the medication is going to be titrated. What does titration mean? It's going to be increasing, decreasing the rate depending on how the mean arterial pressure is responding. So once the perfusion, the required perfusion is achieved, then the interventions are going to be directed towards the underlying condition. Example of this, an excellent example of this, is a question on the NCLEX on a patient with septic shock. And they're telling you, what is the priority nursing intervention? Are you going to give fluids? Are you going to collect a blood culture? Or are you going to administer antibiotics? Well, according to this last tip here, so this is an NCLEX tip, the priority number one is improvement of tissue perfusion with fluids and vasopressors in a septic shock. Yes, we need to treat the infection. Yes, we need to collect blood culture. Yes, we need to administer antibiotics. But that's not the priority. Sepsis protocol says we have about 45 minutes to an hour to administer antibiotics with outstanding results. But BP is better. It's more important. The mean arterial pressure, tissue perfusion is more important. So, with this said, let's go to the actual question. Okay? Remember, the focus of the question was which assessment finding indicates that the infusion rate may need to be adjusted. So what are we looking for? We're looking for something that is wrong. If we have a normal vital sign, a normal lab value, a normal patient response, improvement in the patient's condition, then we do not need to adjust it. So we're looking for something that indicates that this is either not working or we went above and beyond, and now we're getting negative results from the intervention, for the pharmacological intervention. The first thing that we got to pay attention to is the medication that we are administering. The medication is dopamine. Remember that dopamine is a sympathomimetic inotropic medication. So this is going to help improve the cardiac output. It's going to help improve myocardial contractility. It's going to increase the heart rate and therefore elevate the blood pressure, elevate the mean arterial pressure, and improve tissue perfusion. So that is the medication we're dealing with. Answer number one. Do you think that's the answer? What are your answers? Comment in the comment section. I want to see what your answer was. So what do you think is the answer? See number 3. Okay. Well, number 1 says central venous pressure of 6. Well, that is a normal central venous pressure. Remember that we talked about is between 3 to 8 is the normal range. So this is a normal CVP. So that's not my answer. Number 3, a mean arterial pressure of 78. Wonderful. What is the goal? The goal is to maintain a mean arterial pressure above 65. Normal range is 70 to 105. So 78, perfect. So this is not my answer. Systemic vascular resistance of 900. Well, the normal range is 800 to 1,200 dynes per second. So 800 to 1,200 and is 900. So this is normal. So that's not the answer. My answer is number 2, the heart rate. Yes, we want the heart rate to be better. Increased heart rate means that the cardiac output should be better with the medication of dopamine, but we have to be careful because this medication can cause tachycardia and dysrhythmias. So we have to monitor because we might need to decrease the rate of infusion of dopamine, the drip. So if we have achieved a normal central venous pressure, a normal mean arterial pressure, the BP is better, but now we see the heart rate in the 130s, we have to be careful. That is too high. That indicates that maybe the medication now is causing an adverse effect of the medication. I post this quick image here to show you how to calculate systemic vascular resistance. You don't need it for the NCLEX, okay? But I want you to know where the number comes from. How to get the 900 dimes. How is that calculated? So basically, systemic vascular resistance is MAP minus CVP divided by cardiac output multiplied by 80. That's going to give you a systemic vascular resistance. If it's between 800 and 1200, it's normal. Okay? All right, ladies and gentlemen, that is it. Thank you for joining us. Make sure you're subscribed, activate the bell, like this video, share this video with others. If you want to join our membership, in the description and in the comment section, I have posted the link to join our membership. If you speak Spanish and you're looking for a Latino, a bilingual membership, there's more than 170 videos in that membership, excellent courses, content, prioritization, strategies, name it. Everything is there in this wonderful gold membership. If you speak Spanish, if you speak English, the international one, and if you need to contact our academy, here is the number. We have an English advisor and a Spanish advisor. And at the same time, if you need some help with documentation, the application process, our advisors can help you as well. Give us a call. It is a pleasure to be of guidance, to be your mentor in your NCLEX preparation journey. God bless you all. Keep striving for that dream of becoming a registered nurse in the United States. You can do it. Just work hard until that dream comes true. If I did it, being Cuban, English being my second language, if I did it, so can you. All right? See you on tomorrow's training. We're going to talk about a very, very interesting topic. Do not miss the opportunity. I will post it on the chats when we're going to be live. But if you're subscribed to the channel and activate the bell, YouTube is going to notify you automatically when I'm live. Okay? Thank you all. Bye-bye. Take care.